Hi and welcome to another video from urologyresource.com. This video is about lasers and their applications in urology. This is a common topic in the FRCS Urology Technology Viva section. You need to have a basic idea about the principles of laser physics and an understanding of the urological applications of lasers. So what does laser stand for? It is a slightly clumsy acronym meaning light amplification by stimulated emission of radiation, and remember, it's definitely spelt with an S rather than a Z. To understand how a laser works, we have to first understand the basic components of it. Essentially, there are only two. Firstly, we need a chamber containing a medium, which may be gaseous, glass, or crystalline. This is sometimes called the gain or amplification medium, and an example in urology is Holmium YAG. The chamber containing the medium is bookended by a pair of mirrors, a complete one at the rear end and an incomplete mirror with a pinhole through the middle of it at the other front end, allowing the laser beam to pass through it. The second component that we need is an energy source to supply energy to the gain medium. This is usually a flash lamp, such as a xenon flash lamp, or it could be another laser. So how does all this work? We have to remember that the gain medium contains many millions of atoms containing a central nucleus with an orbiting electron. A high voltage electric supply makes the flash lamp tube flash on and off. Every time the tube flashes, it pumps energy into the gain medium. The flashes it makes inject energy into the medium in the form of photons. Atoms in the gain medium soak up this energy in a process called absorption. Atoms absorb energy when their electrons jump to a higher energy level, as you can see here. After a few milliseconds, the electrons return to their original energy level, which is called the ground state, and in doing so they give off a photon of light, as you can see here. This is called spontaneous emission. The photons that the atom gives off zoom up and down inside the gain medium, traveling at the speed of light. Every so often, one of these photons stimulates an already excited atom. When this happens, the excited atom gives off another photon and we get our original photon back as well. This is called stimulated emission. Now, as you can see, one photon of light has produced two, so the light has been amplified. In other words, light amplification, an increase in the amount of light, has been caused by stimulated emission of radiation, hence the name laser. A mirror at the back end of the laser tube keeps the photons bouncing back and forth inside the gain medium. The partial mirror at the front of the tube bounces some photons back into the crystal, but lets some escape in the form of a laser beam. This laser beam is essentially a very concentrated beam of powerful light. So although laser energy is a form of light, it's a very different kind of light to, for example, sunlight or light emitted by an incandescent or fluorescent bulb. It is said to have special properties known as the 3 C's which differentiate it from other forms of light. These are coherence, collimation, and monochromicity, although the third one is clearly a bit of a stretch. Firstly, laser light is coherent. This means that all the waves that make up the laser beam are in the same phase, so they don't interfere or cancel each other out. Secondly, laser light is collimated, which means that all the photons are traveling in exactly the same direction, as you can see here. Laser light is also monochromatic. This means that the light is of exactly the same wavelength, and this depends on the amplification medium used, as we shall see in a minute. The wavelength is dependent on the difference in energy of the electron between its excited and ground states. So moving on to lasers commonly used in urology, I'm sure you'll all be familiar with the Holmium YAG laser, which is found in the near to mid-infrared spectrum. The beam of the Holmium YAG laser is thus invisible. The beam that you see when you're firing the Holmium YAG laser at the stone is in fact an aiming beam, which runs exactly in the same way as the actual laser beam. The KTP or lithium triborate laser has a wavelength of 532 nanometers, and these are known as green light lasers. These are used also in urology theatres, mainly for photovaporization of the prostate. So returning to the Holmium YAG laser, the YAG part stands for yttrium aluminium garnet, by the way. It is used widely in urology theatres, and I'm sure most of you have used it at some point in your training. We've already looked at its wavelength, which at 2100 nanometers places it in the near to mid-infrared spectrum. It is avidly absorbed by water and consequently only penetrates to a depth around 0.4 millimeters in tissue, making it relatively safe to use in the ureter and in the kidney. Perhaps the commonest use of the Holmium YAG laser is for the treatment of urinary tract stone disease. It is effective against all the common types of stones except proteinaceous matrix stones. The laser breaks stones up mainly by the photothermal effect. The extreme temperatures at the end of the laser result in vaporization of the stone. The laser also creates superheated plasma from a combination of the irrigation fluid and liberated calcium ions. These plasma bubbles expand and collapse, giving rise to acoustic shock waves, which may further damage the stone. It is thought, however, that this photoacoustic effect is less important as far as the Holmium YAG laser goes, and most of the stone disruption is by the photothermal effect. The other major use of the Holmium YAG laser in urology is for enucleation of prostatic adenoma. This is the so-called Holmium enucleation of the prostate or HOLEP procedure. At high energy, high frequency settings, the laser cuts through prostatic adenomatous tissue very effectively and also results in excellent hemostasis. The adenoma can be dissected all the way down to the capsule, and the procedure is an endoscopic version of a Millen's prostatectomy, with a laser fiber in fact acting as the surgeon's index finger. Large studies have shown the HOLEP procedure to be safe and effective in experienced hands, with particular advantages for patients with very large prostates and those who are on anticoagulation. Other uses of the Holmium YAG laser include the ablation of small superficial bladder tumor recurrences in the outpatient setting and treatment of urethral strictures as an alternative to the Sachs optical urethratome. Neither of these, however, are widespread in UK practice. The other commonly used laser in urology is the so-called green light laser. These lasers are used for photovaporization of BPH. Green light is avidly absorbed by hemoglobin within the prostatic tissue, which, as you all know, is extremely vascular. So rather than cutting, these lasers result in heating and vaporization of the tissue itself. Initially, these green light lasers were KTP YAG lasers with a wavelength in the visible spectrum of 532 nanometers. These lasers, however, did have limited power, usually 80 watts, and this could result in slow vaporization for larger adenomas. Newer green light lasers use a different gain medium, which is lithium triborate. This has resulted in the ability to increase the power output of the laser to 120 watts, and now there are even 180 watt green light lasers. Photovaporization of the prostate has also been shown to be safe and effective for the treatment of BPH. It can be performed as a day case procedure with minimal bleeding. It must be borne in mind, however, that as part of the procedure, no prostatic tissue can be sent for pathology as it's all vaporized. You might be expected to know a little bit about laser fibers. They are specially designed to conduct laser light from the generator through the endoscope. Structurally, they comprise a silica core with several layers of shielding to prevent light leakage and also to improve the resistance of the fiber to breakage as it's bent and deflected. The two main types of laser fiber are end-firing fibers, which are typically used with a Holmium YAG laser, and side-firing fibers, which are used for photovaporization of the prostate from the green light laser. The Holmium YAG laser fibers come in various sizes, and the smaller size fibers are better to be put down a flexible ureteroscope, as they don't interfere too much with the irrigation flow or the deflection of the scope. Larger fibers are used for HOLEP procedures and also for laser fragmentation of stones during mini PCNL, for example. Laser safety is of paramount importance, and you have to bear in mind that these are powerful energy sources. A key component of laser safety includes all members of the theatre team protecting their eyes with laser goggles. You must remember to protect the patient too by covering their eyes or putting goggles on them as well. There must be a designated laser operator who's responsible for controlling the machine and changing the settings. Clear signage of laser in use along with door interlocks to prevent people inadvertently walking into the theatre are both essential. All laser operators must undergo laser training, and it's important to check the integrity of the laser fiber prior to use. This is usually done by ensuring that the aiming beam is true. When deploying the Holmium YAG laser, it's important to be aware of the laser settings we commonly use. These are given in terms of the energy and frequency of the laser in joules and hertz respectively. Multiplying these two together gives the power of the laser in watts. So for example, when starting lasering a stone, most stone surgeons will use a setting of around 0.5 joules times 5 hertz, giving 2.5 watt total power. When doing a HOLEP, we usually go for 2 joules at 50 hertz, which is 100 watts. The laser settings have a significant influence on laser interaction with stones. High frequency and low energy settings typically result in the formation of dust particles, whereas higher energy and lower frequency settings generate larger fragments. Dusting is desirable when dealing with tricky renal stones through a flexible ureteroscope, when it can be difficult to remove larger fragments. Fragmentation settings are more useful when using a laser to break stones up during a mini PCNL procedure, where the slightly larger fragments can be washed out more easily and you don't end up with millions of tiny particles. Remember, the interaction of the laser with a stone also depends on the stone's composition, so it's always sensible to experiment with the settings to get the optimum result for individual stones. So I think that concludes this brief video on urology lasers. I hope you found it useful, and watch out for more technology videos on urologyresource.com. Thanks for watching.